So first thing, utmost important is to check for A, B, C, D, E. This is known as ATLS protocol. Okay. So what do you mean by A, B, C, D, E? So A is for airway. How do we check for airway? So when the patient is talking to you, that means his airway is clear. If there is any blockage in the airway, then the patient will not be able to talk to you. He'll can make some noise, there will be some sound, but clear talking is not possible. If the anything above your epiglottis, there is block, it will stop the sound. So if the patient is talking to you, then airway is normal. Along with that, we stabilize the cervical spine. So this is the most important step. Before airway, we will do the cervical spine stabilization. How do we do cervical spine stabilization? First, with our hands, we can do. Okay. So we both our hands, so this is the head, one hand on this side and one hand on other side. So this will stabilize the cervical spine, this neck. Okay, this part neck. So once this is temporary stabilization, once this is done, then we can stabilize by two methods. One is keeping blocks, one on this side, one on the other side. So neck doesn't move. Another option is, which is better, is to put something known as cervical collar. Do you guys know what type of cervical collars are there? You can answer. Okay. There are two types of cervical collars. One is known as soft collar. You might have seen people wearing it and roaming around. That is known as soft cervical collar. And another type is hard cervical collar. Okay, this is also known as Philadelphia collar. It has a chin here. Okay, you should always put hard cervical collar so that the spine doesn't move. Okay, once this is done, we are checking for airway. The patient is not talking. So how do we help patient clear the airway? What is the most common blockage for airway? Can you guys answer this? You can unmute and answer, or you can type in the chat box. Most common obstruction to the airway. Not mucus. Okay, mucus is one of the causes, but more than mucus,
Tongue falling back and obstructing.
tongue falling back. Yes, right. Yes. So when tongue falls back, because patient doesn't have his control over the tongue muscle. So what happens is his tongue falls back here and blocks the airway. So what we do is there is maneuver known as head tilt and chin lift and jaw thrust. So when we lift the head and lift the chin, so what you do is with one hand you lift the head and you do something known as E and C. Okay, so this fingers should be just behind the mandible and it should lift it so that tongue gets cleared and the airway is cleared. Other one which you answered, mucus. So what we can do to clear the mucus is there is something called as suction which will be there. Use it to clear the airway. Okay. So now we are done with the airway. So we check for airway whether patient is talking. Done. If patient is not talking, we do the head tilt, chin lift, and jaw thrust maneuver. Then we go for something known as.
Sir, I have one doubt.
Huh.
In cervical injury, suspected cervical injury patients,
Okay.
can we do that chin lift and head tilt?
We can do the chin lift and jaw thrust. We can't do the head tilt. Okay. So what happens in head
Okay.
tilt is we are lifting the head. So this you can see this cervical spine is getting tilted. If we are suspecting, what you have to do is keep the patient flat and just lift this jaw. Chin lift and jaw thrust can still be done in cervical injury patient. We should not do head tilt. Okay.
Thank you, sir. Thank you.
Okay. Fine. So we are still not sure about cervical injury. So what we do is we just do chin lift and jaw thrust. Okay. So now patient airway is clear. So next we come for breathing. How do we check for breathing? easiest way, which like we do in regularly. We even do it in like recently in COVID and all we used to do. Can you guys answer me?
Saturation, sir.
Yes, saturation, SpO2. So what is the normal saturation?
Above 95, sir.
Yes, above 95. Even up to 94% will accept. If it is below 94, it's abnormal. But that should be checked because in some chronic patients like COPD patients, their saturation level is itself around 86. Now, if you check, he has 86%, we'll say that he has breathing issues and we can't intubate him or do anything more because his normal saturation is low. So now in trauma patient, so it's below 94. Okay, what will be the cause? So there is something mnemonic called as ATOM FC. First A is airway obstruction. Okay, which we checked here above. Okay, next is tension pneumothorax. Not just pneumothorax, tension pneumothorax. What happens in tension pneumothorax is air is coming into the pleural cavity. Okay, this is the pleural cavity, this is the lung. Okay, so air is coming inside, but it's not leaving out. So it goes on, pressure is in the lungs, and lungs goes on decreasing in size, and he won't be able to breathe. So this is known as tension pneumothorax, due to which patient is not able to breathe and saturation drops down. Next is open pneumothorax. Here, both way air is going, but this is a less severe form, but still patient is not able to breathe. M is massive. Anything? Okay. Next one is, sorry. Next one is massive hemothorax. Can you tell me what is hemothorax? Just like pneumothorax is air. Hemothorax is blood inside the thorax or pleural cavity. Okay. Next, F is flail chest. Anyone knows definition of flail chest? When do we call it a flail chest?
A deviation of
Yeah, just broken ribs. All the broken ribs will be called as flail chest. Not air, no. So 10. So these are the ribs. Okay. So 3 consecutive ribs, at least at 2 places. So what happens is, whole segment is separated out. Okay. Whole segment gets separated out. Okay. So this part is moving in separate to this. So when patient is breathing, this rest of it is expanding, but this part is going in. This is known as flail chest. So multiple rib fractures causes flail chest. And next is cardiac tamponade. So what happens is, just like lungs, even heart is covered by a pleura. Okay. So when that is filled with blood, it is known as cardiac tamponade. The heart is not able to pump properly. Okay. So this is problem of breathing. Okay. Next, coming to circulation. How do you check for circulation? Type in the answers. How do we check for circulation? How do we know whether circulation is good or not? Yes, pulse rate. I check for mainly pulse. Where do we check for pulse? Yes, rate, volume is good. So where do we check for pulse? Carotid pulse, anything else? Radial, femoral. Okay. So circulation pulse rate should be checked in radial, and volume and character should be checked in carotid. Okay. So what is the problem in trauma? Why we can't check regularly in radial pulse? So what happens is, what is systolic pressure? The pressure with which heart is pumping. Okay. So in any trauma, the patient will be having reduced BP. Okay. So reduced blood pressure. So suppose systolic is around 90/60. So what happens is the pressure with which heart is pumping is not enough for you to feel the radial pulse. Okay. So when BP is less than 90, then it is difficult to feel radial pulse. Then we go for carotid pulse. Okay. So check for pulse rate. Pulse rate will be high or low. How will be the pulse rate? How will be the BP? Okay, someone answered dorsalis pedis. It's very difficult to check dorsalis pedis in trauma patient because BP will be low. Body will prioritize. Okay, heart and brain will get more importance than limbs. So pulse in trauma patient when BP is low, yes, tachycardia and hypotension exactly. So heart is pumping fast, but high heart rate, but it doesn't have enough pressure and doesn't have enough volume. So reduced BP. This is known as hypotension. So now BP is reduced. So how do we bring it back? What do we do to bring back blood pressure? IV fluids, yes. What type of IV fluids? There are two types of fluids, crystalloids and colloids. So what will we give? Crystalloids, exactly. So first thing is stop any hemorrhage, external hemorrhage which you can see. Suppose patient has cut his limb, upper limb, okay? It's cut and there is blood flowing out of it. So what we do is we put a tourniquet here and we stop this bleeding. Because until we stop this, anything we give will be going out. It's like you put water in a uh, jug or box and there is a big hole. It will be all flowing out. So what you have to do is any external hemorrhage, okay? Any internal hemorrhage, immediately we can't stop. Any external hemorrhage, we need to stop. Okay. Then we give crystalloids. Okay. Can you name the crystalloids? What are the crystalloids? Yes, ringer lactate. Stop losses and fluid restriction and inotropes. Exactly. Inotropes, we see if BP is very low, then we start on. Okay, NSRL. Very good. So, ringer lactate, sorry, ringer lactate and normal saline are preferred always. Okay. Once this is stabilized, there is something known as permeability membrane through which these fluids leak. So that time we can give colloids. And along with this, we do a very important thing. Can anyone tell me what important thing? Some test we need to do. Some test we need to do along with starting the IV fluids. We check for blood grouping. We send for blood grouping so that we can transfuse blood. Okay. So we are starting IV fluids. Where do we insert? Where do we insert the cannula? Where? Which? Where do you insert the cannula? Which cannula do you insert? 18 gauge. Good. Wide bore. Good. Anything else? Where? 18 gauge. Bhavna, can you tell me color of the 18 gauge needle? Yes. Green. Yes. So we use 18 and 16 gauge needle. So as much as fluid needed, we can push. Okay. Where do we insert? First, we try for peripheral lines. Okay. Peripheral lines. If we are not getting peripheral lines, there are two ways. Then we try for external jugular vein. If that is not there, there are two ways. One is intraosseous. So we puncture the bone and send it through it. Another is central line. Okay. So by this way, we send the fluids. Okay. Then after fluids, we go for blood transfusion. Okay. Blood is transfused. The patient is stabilized. Then we check for where is the hemorrhage, where all can blood loss be. So these are the places: intrathoracic, intraperitoneal. We'll go from head to toe. Okay, retroperitoneal. Okay, then thigh compartment. Any femur fracture, thigh compartment. Any abdominal injury, intraperitoneal. Chest or lung or heart injury, it will be intrathoracic. Okay, and floor. Sometimes what happens is there is some perineal bleed in female. There is somewhere bleed. You should check on the floor or the bed. So there will be continuous bleeding. If you don't check, the patient will eventually collapse. Okay, so we should check all these places for blood loss. Okay, so management is done. A, B, C is done. Next we come for disability. Okay, how do we check for disability? There is a mnemonic A, B, P, U. So A is awake. Patient is awake. Okay, he is talking to you. So his disability, there is no disability. Suppose patient has any tracheal injury, or patient has laryngeal injury, or patient has any head injury due to which he has lost his consciousness, then he won't be able to talk. Next is verbal. Okay, you tell a patient command. Okay, tell him hold my hand. Okay, tell him to move his fingers. If he does that, he is following verbal command. Next comes pain. He's not awake, he's not responding to verbal command. So what we do is we check for pain stimulus. So patient will respond to painful stimuli. So when you press his like when you give any painful stimulus to his limb, he moves his limb away from you. Okay. Next is unresponsive. So patient is not responding at all. Okay. So next we go for something called as exposure. We'll completely expose the patient. We look for any hemorrhages. Okay. Then we completely cover the patient always. Because, can you tell me why we cover the patient? Why do we cover the patient? Yeah, heat conservation. Exactly. To prevent hypothermia. There is something known as lethal triad, which we'll talk later. To prevent hypothermia, we will completely cover the patient. So our primary survey is done. A, B, C, D, E is done. Anything, any doubt, you can ask me now. Okay, then we move for something called as secondary survey. This is also known as H2T, head to toe survey. So we look for any injuries now. We go in, we look at each part. Okay, we first scalp, then eyes, then ears, mouth. From there till toes, all the parts should be examined for any injury. Okay, so this is done. So after secondary survey, we can always go for tertiary survey. Okay, so that is done after patient is admitted. We have stabilized him. We have shifted him either to ICU or ward, depending on seriousness of the patient. There we do something known as tertiary survey. Okay, so we have done primary survey, we have done secondary survey, we have done shifted the patient, we have done the tertiary survey. Okay, now a subtopic called as GCS. What is GCS? Glasgow Coma Scale. Okay, we see written as 13 by 15, 12 by 15. So how do we assess the Glasgow Coma Scale? There are three things we assess. One is eye, one is verbal. So it is how it is written: E3, V4, M5, something like this they write. Okay. So this is how it is written. You should not write 12 by 30, 15. It should not be written like this. It should be total score. If it's not there, you can write, but you should always write E, V, and M. So what is I? So the maximum score is 15. The minimum score is 3. Okay. So it goes like always, it's like 4, 5, 6. It goes in this order. Okay. So I, when it is 4, when it is spontaneous, patient has opened his eye He is looking everywhere. Though this is 4. Okay. To sound, you call his name. You call, suppose his name is Ramesh, you call him Ramesh. He opens his eyes. So this is 3. To pressure or pain. So you give pressure, sternal pressure, then he is responding. No response will be 1. Okay. So this is I. Then we go for verbal. Okay. On verbal, we check for oriented. He is talking to you. He is you ask his name, he is telling his name. Then he is 5. He's confused. He is talking something. You ask his name, he is telling he fell down, he is telling his mother's name, something like that. Then it is 4. He is telling words. I, bike, like that he is speaking. He is not speaking in complete sentences. Then it will be 3. He is making sounds. Like that he is making sounds, but you would not understanding any sounds. It's like Jadu. Oh, he is doing. You don't understand what he is talking. What just sounds. It will be 2. Again, none will be 1. So this will be verbal. Okay. Then moving to motor. Motor obeys command. What do you mean by obey command? You tell him to lift his hand, he'll lift his hand. You tell him to hold your finger, he'll hold your finger. This will be 6. Localizing pain. You ask, you tell pain, he'll show that. It's suppose his hand, other hand, he'll show with this hand, the other hand. Then something known as normal flexion. On pain, he just flexes his hand. Okay. Then abnormal flexion. So you give painful stimulus an arm, he should be flexing the arm. He is abnormally flexing, that then it will be, sorry, not 5, it will be 3. Then extension. The patient is in extension, then it will be 2, and again none will be 1. Okay. So we have understood the Glasgow Coma Scale. We write it as, patient is very well now. So we write it as E4, V5, M6. Then we need to transfer blood. What are blood and blood products? What all blood products do you know? Okay. What all blood products do you know? Yes, PRBC, FFP, good. Anything else? All blood products you give, not just in trauma cases. What all blood products are there? Bhavna is answering well. Okay. So PRBC, FFP. What is FFP? It is fresh frozen plasma. Platelets. Cryoprecipitate. So these all are blood products. So in trauma patient, most important is PRBC. But after that, we give in ratio of 1:1:1. Because we are in India and in government sector, it's difficult to get everything. So what we go for is around 3:1:1 at least should be given. Okay. Ideal is 1:1:1. So we transfuse blood products to the patient. The patient is now stabilized. So then coming for lethal triad, which we talk. So this is acidosis. Okay. Hypothermia and coagulopathy. So we should avoid this happening. So for acidosis, we check for ABG. Okay. Dr. Pramod has taught you very well how to read an ABG. If you want, we'll do another class. So patient is in metabolic acidosis. So what we give? How do we correct the acidosis? Yes. Soda bicarb, exactly. Soda bicarb. How do we prevent hypothermia? We cover the patient and we also give warm fluids. There is severe hypothermia, then we give something known as intraperitoneal fluids. And for coagulopathy, we should check for INR, PT, INR. Okay. So we check for PT, INR. And we have to prevent coagulopathy. So we should continuously monitor PT, INR. And when there is signs of coagulation, you should give antithrombolytics, anti-aspirin, so to prevent it. So patient does not go into DIC, disseminated intravascular coagulation. This is the most severe form. So the patient is now stabilized. Rest of the things